Hello, everybody. This is Skin and Wound Care Update. Make sure you're on. All right. All right. My pleasure to introduce Darcie Peterson. She is a certified wound, ostomy, incontinence nurse. She is has an adult and gero NP, and she graduated in 2010. She's works inpatient mostly at St. Joseph's Hospital in Orange since 2012 in a role that was made for her. It was to oversee the revamping of the EMR for wound and ostomy assessments. She's a founding member of the Epsilon Beta chapter of the Sigma Theta Tau and served several board positions, president, vice president, scholarship chair, and was the first student to serve as student rep for the Orange County CANP chapter. And she's been a primary educator in regards to skin and wound care at St. Joseph since 2007 and has developed tools for the staff to improve the patient's outcome. I'd like to welcome Darcie. Thank you.
Thank you. Good morning. So just a warning, there's some ugly pictures, so I hope you all are ready, but I'm sure you knew if it was about skin that could happen, right? So we have some objectives here. So this is just like a basic overview, but a basic understanding of the anatomy and physiology of skin. I also want to go over the 6 stages of pressure ulcers. I want to differentiate between pressure ulcers and moisture-related skin damage and other wound types, because sometimes there's a lot of confusion. So maybe you guys see these in your practice, so it's just kind of to give you a little bit, so next time you see it, you might be like, oh yeah, I remember, that's what that is. There's some assessment tools, which we'll just briefly go over, and then also we're going to talk about some pressure ulcer prevention techniques, treatment principles, and I know it sounds really basic, but how to pack a wound. So let's start with the anatomy and physiology of the skin. So this is just a nice picture. I don't know if this pointer's not working. Oh, maybe. There. So, remember we have the dermis and the epidermis. People always think I'm crazy because, I'm a fanatic about skin. Skin is our largest organ, and people forget that. And people will be like, oh, I'm trying to take care of the patient who just, had a heart attack. Why are you worried about their skin? Well, it's the largest organ. So, and remember the variance in the thickness of our skin is very variable. So you can get a pressure ulcer on the bridge of your nose a lot quicker than you can on the bottom of your foot. So, the cells, these are special cells, they elongate, and, they do your nails and hair. I didn't bring my really ugly pictures of the really long nails. Another important thing to know is, your pH should be between 4.5 and 5.5. You need to keep it well lubricated, and it's elastic. Okay, so what does our skin do? So it helps regulate our body temperature. It helps with sensation, okay? It prevents us to lose a lot of fluids, because remember, when you have a patient who has really bad burns, they're losing a lot of fluid, okay? It acts as an excretory organ. That's why we sweat. It provides us for an interface between our environment so that hopefully we're not getting, microbes and stuff. It protects our inner tissues from invasion, and it also helps us to synthesize vitamin D, which in California, I think a lot of us wear sunscreen, so we're maybe not getting enough vitamin D. Okay, aging of the skin. So this is important because remember, we have a lot of patients that are getting older now. So it's really important to understand the changes that happen. So they get a thinning and atrophy, and this is because of the flattening of the REAP pegs, which I'm going to show here in just a second. Their skin can be easily traumatized. They can just barely touch something and they get a bruise or, bleeding in the tissue. They also lose that elasticity all of us do as we get older. Our immune responses slow down. Our sebaceous glands don't work as well, and our thermoregulation. So they also have fewer sweat glands. And the sun exposure is going to be the most obvious cause for them having wrinkles. So that's why we all wear sunscreen, right? Because we don't want to get wrinkles. So this is just a picture there. So these are the REIT pegs. And I just like this picture because it really shows, it reminds me of those egg crate mattresses that we don't use anymore, right? But basically like taking 2 egg crate mattresses and fitting them together. But as a patient gets older, those little pegs, the little area that protrudes out, they kind of flatten, which is why the skin slides and moves around a lot more, because it doesn't have those little pegs, you know, holding them. So it also looks kind of like a waffle iron, right? So this is why patients, when they get older, this junction becomes flatter, so the skin becomes more mobile. They've lost their elasticity, and then they get skin tears. So I'm sure you guys have all probably seen a skin tear. This is a pretty nasty looking one. But what you want to see here is, you know, this area here we call the hood. So if you have a patient that comes to you like this, what you really want to try to do is, hopefully they're coming to you right after the injury happens, you can try to use like a cotton tip applicator and try to approximate this down as much as you can. A lot of times in our ER, they just drive me crazy because they cover these with transparent dressings, and once you put that on there, if you take that off, you're going to remove that hood. So once it's on, you might as well just leave it on and trim the edges. But if you can, it's much better for the patient and the healing process if you approximate this and let their body heal itself versus trying to put something artificial, okay? So this is how it looked after it was approximated. So you can see we couldn't get all the way to the edge, but we got part of it covered. And we just used steri-strips to secure that down, okay? All right, so the geriatric skin tips. On your older patients, if you have it in your place of work, please try to use adhesive remover when you're taking things off of their skin, because remember, their skin is much more fragile. You also want to secure the skin, so you want to hold the skin taut with your fingers as you're trying to remove stuff versus just going like, okay? That's really bad on older patients' skin. It's bad on anybody's skin, but especially older patients. So you don't want to just rip things off, okay? Because we have actually seen patients who have gotten damage from the dressing we had on the patient because we're not cautiously taking it off. Okay, and you also want to consider friction and shear. Friction and shear are very real, and especially in the hospital bed. You know, you have a patient, you're putting them in the bed, and you're sliding them around, trying to move them. So friction and shear can cause a lot of skin damage, especially on those patients because the REIT pegs are flattened out, and then they're just going to be loose, and then they just pull. So the next thing you know, your patient has an injury. Okay, this is just a fun cartoon. I don't know if anybody here remembers Dennis the Menace, but this is Dennis the Menace, and you know, he's looking at Mr. Wilson, and he's like, I wonder how they got skin big enough to fit him. So that just proves the point of how elastic our skin is. Okay, so another thing to remember about our skin is that as we're walking around interacting with the environment, you know, there's a lot of things floating around. So we have microbes on our skin all the time, which is why doing a skin culture or even wound cultures, a lot of times you're not going to get a whole lot of information from them because most of us have Staph aureus on our skin all the time. So, you know, you're not going to get a really good sampling of what's going on with the skin, okay? So these are just some of the residents that live on our skin. So they might look familiar to you, some of you all. Okay, so now we're going to talk about pressure ulcers. Okay. So pressure ulcers, so the NP, UAP, they're kind of like the gurus about pressure ulcers That stands for National Pressure Ulcer Advisory Panel. So the most recent descriptions of tissue damage were in 2007. So I think it's getting about time for them to update their information. But you can see we have a stage 1s through stage 4. There is no such thing as a stage 5. I don't care what anybody tells you, okay? We have suspected deep tissue injury, which you'll see it called STI for just suspected tissue injury, or SDTI for suspected deep tissue injury, and then UST is the most common abbreviation we use for unstageable, okay? So this is an example of a stage 1 pressure ulcer. So remember, by definition, the area needs to be non-blanchable. So if you see this on your patient, the first thing you're going to do is try to blanch that area. So patients can have blanchable redness, which would be a precursor to alert us that maybe we need to start taking some kind of prevention, okay? But it's harder to see on darkly pigmented patients, of course. So on them, this area may just feel like a different temperature than the surrounding tissue, or it may feel boggy. I like this little picture down here because it kind of gives you an idea of how far down is that damage going, okay? So stage 1s, a lot of times if we start a prevention and so this is the patient's heels, right? If we elevate those heels on a set of pillows and they're not digging into the bed, then hopefully that area is just going to go away, okay? So that would be your intervention. But of course, once you see that on your patient, you know they're at high risk and you're going to be monitoring them. Because I always tell the nurses, let's think more about prevention instead of reaction. So we try to think what is something we can do as a prevention rather than waiting till the injury happens, okay? So this is just a stage 1 on the sacral coccyx area. So you can see it's very bony there. And, you know, I would say to my nurses, hey, let's put something on this area. Let's protect it. So we usually put a foam dressing on there because since it is bony, we don't want to wait for something to happen. We want to try to protect that patient because this patient may have come from home and now we're putting them in a hospital bed and their movement's going to be impaired. Okay, now this is a stage 2. So stage 2s, again, it's going to be partial thickness. So your stage 1 and your stage 2 are what we call partial skin loss. So that means it's only going into the epidermis. It does not go down into the dermal layer. So again, you can see that here in this photo, okay? So a stage 2 is like, I mean, I'm pretty sure most people in this room have gotten a new pair of shoes and you wear the new shoes and you get a blister, right? So when the blister pops and that little hood or covering comes off, you have that really shallow wound. That is similar to a stage 2. So if you kind of keep that picture in your mind, that kind of helps you because pretty much everyone's experienced that at least once in their life, okay? And you're not usually going to see any slough in these wounds. It's just going to look kind of pink or red and be very shallow. So remember, because the stage 1 or stage 2 is a partial skin loss, you should never get a scar from that. So, I mean, most of the time you don't get a scar when you get a blister, right? So that's one thing to keep in mind. Okay, so stage 3, we're getting a little bit deeper. Usually not always on a stage 3, but a lot of times on a stage 3 you may see some slough. So slough is just like this thick, yucky looking stuff. It comes in many different colors. So, you know, sometimes it's yellow, sometimes it's brown. But if you see slough, that means you're now into the dermis, okay? So when this heals, this patient is going to have a scar, okay? And the other thing to remember is once you've injured your skin, it's never going to be back to 100%, okay? You're always going to have healing. Well, hopefully you're going to have healing, but you would probably get somewhere between 80 to 85% of the original strength. So when you see someone coming in and you see scarring, you're going to immediately know that's an area you have to kind of keep a closer eye on. And I work in inpatients, so that's why I say when you see them coming in. But even if you're seeing them in the office, you got to be aware, because if this patient has scarring, you're going to know they have a potential for breakdown in that area. So it's something you're going to want to monitor, okay? Now this is a stage 4. Oh, I'm sorry, this is unstageable. Did I skip stage 4? I did. How did I do that? Sorry. Stage 4. So stage 4, you can see this is bone. So one of the defining characteristics of a stage 4 is you're going to see bone, tendon, or muscle. And if you've never seen it, once you see it, you're never going to forget it because it's just very defined. I mean, it has its own look. It looks way different than tissue, okay? So when you see it, you'll know, and you're going to be, that's very serious. Now, the thing to note about this patient is we can see this open area here, but you see this marking that's all the way out to here? So this is what we call undermining. So you can actually take a Q-tip and stick it in that wound all the way out to that line. So you notice it kind of varies. But that means that this is sort of similar to an iceberg, right? Because what we're seeing on the top is way different than what's underneath, okay? So a lot of times these wounds are very difficult to heal because one thing you need to know also is wounds are going to heal from the bottom up. So we have to, if we have a lot of slough or stuff going on, we have to clean that out in order to allow the wound to then fill in from the bottom up, okay? So this is our suspected deep tissue injury. This is one of the newer definitions by the NPUIP in 2007. There's a lot of controversy around it, but this is very common in people that fall at home. So say someone falls at home and they fall on their hip. When you come into the hospital and you check their skin, there's really nothing there. And then you're getting ready to send them out to the rehab center and you're checking their skin before you're discharging them. And lo and behold, you see bruising. Or you see this, it's defined by this purplish discoloration or like a blood blister. And the reason that is the tissue, when the patient initially falls, the bone impacts the tissue way down here at the base. And so it takes a few days to evolve or declare itself. They actually have evidence that shows it can take up to 10 days for this injury to show itself. So it's really important when you're documenting that if you know your patient fell, that you're documenting that. And if they were down for a really long time, you also want to document that, okay? Sometimes these open up and it's a very superficial skin damage, like maybe a 1 or 2. Usually a 2, because you wouldn't have skin loss really on a 1. But I have to tell you, almost all of them that I've ever seen open up are stage 3 or stage 4. And it makes sense because it's starting way down here, right at the bone, okay? So you'll notice that discoloration. Now, unstageable. So unstageable means that we have a lot of slough, and you can see here I've listed a lot of the different colors of slough. This clearly here is a slough. So if you're documenting this, you could say that, maybe 60 or 70% of that is covered with slough, and then the other 30%, is maybe a stage 3. But you always want to stage to the highest level. So if you had to pick one, you would go with your unstageable, okay? But the reason that it's unstageable is when you have all of this slough covering the wound, and you can see down here in this picture, we don't know what's going on underneath that. We don't know what's happening. So again, this slough has to be removed somehow so that we can then try to heal the wound from the bottom up, okay? So these are other pictures of unstageable. Now, you can see this one. I mean, if you see all of this erythema and stuff like this, and your patient's coming in for sepsis, I mean, you're going to be calling in a surgeon for a surgical consult because they're probably going to need to take that patient to the OR and clean that out, okay? Something like this one again, you can see the lines going out. You can see there's some slough in here. You can see it's pretty deep. So you always want to measure your undermining. And you're always going to think of your wound like a clock. So the patient's head is 12 o'clock, the feet are 6 o'clock. So this way you can describe to other caregivers, you know, patient has a wound, and you could say that there's slough probably from like 12 to 6 o'clock. And that just helps them know when they're analyzing the wound, is it staying the same? Is it getting better? What's going on with that wound? Okay. All right, so how do we prevent pressure ulcers? Well, we don't leave patients in the bed, you know, at a 30-degree angle for really long time periods. I mean, sometimes we have patients on tube feedings and stuff. We have to do these things, but we also may need to start some kind of a prevention measure, okay? When you have your patients laying, you know, in bed, I always tell them if they're not eating, they shouldn't be flat on their back. Because how many times you go in, I don't know how many of you work acute care, but you go in and you see the patient, they got this huge pressure ulcer, and they're flat on their back. Drives me crazy. So just even turning just a little of a tilt, it doesn't have to be a lot, will help. But you don't want them laying directly on their hip, because now you're going to cause pressure between the hip bone and the skin, and maybe you're going to have them break down there. I always say put a pillow, if your patient's kind of laying to the side a little, put a pillow that you can put one pillow that's usually on most patients can cover their knees and their ankles, so you prevent those areas from hitting each other, okay? And you also want to avoid dragging patients across the bed, because again, that's talking about our friction and shear injury that we want to prevent. So the ICU nurses get mad at me sometimes because we have patients that are hemodynamically unstable. So they're like, no, you can't touch them, you can't move them. So even just taking and I'm stepping away here, but even just taking a little washcloth and tucking it under them just a tiny bit, you're still changing that pressure to the sacral coccyx area, which is what you're trying to protect. Because sometimes for certain patients, they have to lay on their back in the ICU for 3 days. And then guess what? You turn them over, and now they have something. And now it's on the hospital because it happened on your watch, right? So you have to make sure, and if you have these patients that are refusing to reposition, you need to document that you have educated them or the family that, you know, why they need to reposition to prevent skin damage, pressure ulcers. And that's just to cover yourself, because what you don't want to happen is, you know, someone to come in and say, well, oh, they never told me that. They never educated me about that. And you have to keep repeating the education. Just because you did it once doesn't mean the patient's going to get it. Okay? So prevention, one of the things we can do is manage moisture from incontinence of either urine or stool. Because remember, I was talking about the pH balance. So urine and stool do not fall within the pH balance of 4.5 to 5.5. So any contact that they have with skin is different, and that's why it starts causing breakdown. So if you have a patient who has incontinence of one or the other, or even both, then they're going to be at higher risk. So, you know, in the hospital, we try not to use Foley catheters anymore, right, because of COTI. So we have to just make sure we're managing that. And if your patient is with it enough, they should be able to tell you that they've gone so that you can come in and, I mean, maybe you can't get there right that second, but it's way better than going in and find out they've been sitting in this stuff for an hour, okay? You also want to manage your nutritionally compromised patients. So on our patients in the hospital, when they have a stage 3 or higher, we have order sets, and that allows even our regular nurses with a physician's order that says initiate designated skin set, they can initiate those orders, so after hours or on the weekends when we're not there, they can start these things. They don't have to wait for us to come in. So it empowers them to be able to start these interventions. Dietary can come in, do a consult, see if there's anything they can do. Because a lot of times when you check these patients' albumin or pre-albumin or their protein, they're all low. Because these patients, a lot of them are chronically ill. And it's not something we routinely check. But those things are going to impact how the wound heals. The other thing is if you have diabetic patients, you want to make sure that they have good glucose control. So you want them to aim for 140 or below at all times, okay? Because that is going to help keep the wound environment surrounding that area that's trying to heal in a better condition so that hopefully they can heal faster. I also tell the patients, patients say, well, what can I do to make this wound heal faster? Well, you're diabetic. This is what you do with your blood sugar. If they're not diabetic and they're not impaired for renal, you also want them to have a high protein diet. So yogurt, fish, all of these things, cheese. You want them to eat these things because that also helps to raise that level and increase their chance for the wound to heal. Okay? If your patient can't ambulate, then you just want to make sure you're changing positions every 1 to 2 hours. I like to use pillows. We've had pillows forever. They're cheaper than heel protectors. Some of the heel protectors actually cause damage because they're put on improperly. So therefore, I just like pillows because you can see what's going on and you just put them there. They're easy to get. If you have a patient who's sitting up, you want to try to get some kind of a chair cushion. And please don't use these donuts. Donuts are for eating, not for pressure ulcers. Okay, please do not use them. Because the problem with those is they blow them up super tight and then you're causing an area that can cause pressure. The chair cushion that I'm talking about that you really want to use kind of looks like a waffle and it looks like it needs to have more air in it. But the reason it looks like that is because as the patient moves, the air moves around in that thing and it's not super tight. So then they're sitting on something, but it's not causing pressure. I can't convince the surgeons to quit using those, but luckily we don't do too many hemorrhoidectomies anymore. Now, this is just a picture this is just to show you Barbara Braden is a real person, okay? I actually met Barbara Braden at an NPUAP conference. She's world-renowned, and she is a real person, very nice lady, and she developed a tool that I'm sure almost everybody in this room is probably familiar with, right? It's a risk tool that we use, okay? So this is my picture with the iceberg. So I like that because to me, that's a lot of times you see this, but this is what's really going on underneath, okay? So when you're thinking about skin and you want to talk about prevention, you want to talk about your, surface selection. Does your patient need to be on a different type of surface than just your regular bed? Most hospitals now have pressure redistribution beds or something that's a little more high-tech than the old foam mattresses we used to have. You want to make sure you're turning them. The I is for the incontinence and the N is for nutrition. So just a really neat way to remember these things that are important. Okay, now we're going to talk about IAD and MASD. So IAD stands for Incontinence-Associated Dermatitis. So any of us who've been nurses for a while, this is what we used to call excoriation. So now it has a fancy name. And MASD is moisture-associated skin damage, which you may sometimes hear called MRSD, which means moisture-related skin damage. So basically, the cause of this is not pressure, it's related to moisture. Okay? So this is just a picture of some poor patient that has been having incontinence, and you can see it's just all around the rectal area. Now, there's no pressure in these areas, and one of the defining characteristics is if I press on this, it's going to blanch. Okay, so when you see this and you're not sure, you can just press it and see if it blanches. So if it's blanching, it's usually not related to pressure. And another thing is, pressure ulcers are usually over a bony prominence, although we do have device-related pressure ulcers nowadays. But that's because it's something we put on the patient improperly or they laid on it, and that's what caused the pressure, okay? And those are caused by all kinds of things, trachs, NG tubes, sequentials, all of those kind of things, which you wouldn't see in the outpatient world, but in the inpatient world, unfortunately, we see it all the time. So for this patient, we're going to just try to do some good incontinence care and just make sure maybe we're putting some kind of ointment on that. Because what you want to do is protect that skin. And you want to use something like a zinc based ointment on there, because then you're putting an interface between the patient's skin and all of that incontinence. Okay, and when you use those kind of creams, you want to make sure you don't try to scrub it off. I mean, how many people probably in here use Desitin on the babies, right? So when you use Desitin, you apply it and you just clean off the topsoil layer. That's how these ointments work for our patients as well. You don't scrub it off. You take off the soiled area and reapply. And I say, if you know your patient is going to have diarrhea, which sometimes we know when we give them CT contrast or other things, it causes this. So let's be preventive. Let's put the cream on before all that starts, right? Let's think ahead, because then you're saving your patient from all this pain, and you are causing yourself probably less work, right? Okay, so this is an IAD tool, and you can just get this online if you like. It's by, I think her name is Jenkins. But this is a tool that is used to identify the different classes of IAD. So as you can see, this patient has a way worse condition versus this last slide I showed you, right? But now, what do you think about this patient? We see red, raised satellite lesions on this patient. So right, it has a fungal component, okay? So we have to address that. So this is not a patient I would necessarily put cream on because it's fungal and it's already super moist. This is a patient that you probably want to get some kind of an antifungal powder to put on, because then you can help dry it up and you're treating that at the same time, okay? So that's important to know. Another two defining characteristics on your IAD is it's usually, especially if there's a fungal component, the patients are going to complain of itching or burning, and it's going to be kind of spread out, diffuse, okay? All right, so now we're seeing also more bariatric patients. So this is Intertrigo or Candidiasis. So we see this a lot of time in the body folds. So in the pannus, under the breast, and again, this one has a fungal component. There are actually some that I didn't bring a picture of one, but a lot of times you'll actually see the skin is actually even just a little linear opening that's, you know, maybe bleeding. That is also caused by this moisture. So what we have to do is dry this up. So the doctors drive me crazy because they try to order antifungal ointment to put in there. I don't like that. So I say either use your powder, okay, or they have a really cool silver impregnated cloth, which basically you put it in to the body fold in a single layer, and you make sure that it's extending out 2 or 3 inches. So when I go in and it's all wrinkled up and inside of the fold, it's actually making it worse. So you lay it inside and have it extend out. It wicks that moisture away and it evaporates into the air. Okay? And if you have patients that have minimal funding or issues with that, maybe they can't afford it. You can order it online, patients can, but they could even use just an old t-shirt and cut it up. It's not going to give them the exact same results, but it's still going to be better than them doing nothing or trying to cram powders and all kinds of things in there. The one thing you don't want to do is you do not want to use like an ointment or a powder with the cloth, because it will then clog the pores so they can't wick everything away. So just keep that in mind. So this is just to remind us we always have to check the folds. Because a lot of times we go in, we look at the patient's skin, oh yeah, it's good. But look what happens when we open up that fold, right? So if you have these patients, especially the bariatric patients, a lot of times the legs do look like this, but then when you actually separate it out, you're going to find that they might have something going on in there. So you want to take care of that, okay? This is my moisture-related skin damage to the gluteal cleft. That's a fancy way of saying butt crack, okay? So that is the new term. It is your gluteal cleft. But I have nurses who will say that's a pressure ulcer. So when I go in, I assess it. If it blanches, it's not a pressure ulcer. Did the patient lay on a pencil? I mean, some of these cracks, you really have to open them, right? So how would this be related to pressure, right? So you got to kind of think about those things. And you know what? You do not have to be a patient of size to have this happen, because we all sweat. And so sometimes we just have that happen. And it doesn't matter how large we are, okay? And it can be very painful if it's happened. So again, you want to try to think outside of the box and figure out what the cause is, because you want to treat it properly. So for this, because it's moisture related, we need to put something on there to try to keep it drier. Okay. This is our moisture damage reference sheet. So this talks about the Incontinence-Associated Dermatitis. It talks about our Intertrigo. Two things I haven't really talked about is, we have patients that a lot of times around their wounds, just because that wound has a lot of exudate, it's causing moisture around the wound and it's damaging that skin. So we have peri-wound moisture. And a lot of our patients with stomas, just because of the effluent and having to wear an adhesive and all that, they get issues with their peristomal skin of having skin breakdown from the moisture, which is a whole nother talk. Okay, so treatment, principles and options. So this is the time principle, which I like, because again, it's something easy to remember. So if there's non-viable tissue, we have to get it out, right? Because our wound's going to heal from the bottom up, okay? If there's infection or inflammation, we have to address that, okay? If there's a moisture imbalance, we have to address that. So wounds usually will be either wet or dry, so we want to keep them right in the middle. So you want a moist wound environment to optimize your healing, okay? And if you have the edge of a wound that's not advancing or it's undermined, or if the edges are rolled, so the skin is kind of funny. If you have a wound where the edges roll in, you could have like this huge hole, but if the edges are rolled in, the skin thinks that because it's touching other skin, it thinks it's closed. So, if you don't re-traumatize that area, which I know sounds mean, but if you don't re-traumatize that area and wake that skin up, then that wound is always going to stay open. It's not going to heal. So we don't do this. A surgeon would either have to, mechanically, sharply debride it. But in the hospital, sometimes when we do have that, we can use silver nitrate sticks, because essentially then you burn that tissue and you re-traumatize it, and then it kind of wakes it up, and it'll start working again. Okay, yes? I am, but our hospital policy does not allow me to do that. But yes, it is within my scope. It's just that we don't do it where I practice. But yes, WOCNs can do mechanical debridement. But, personally in the hospital situation, the patients are so sick and they're at risk for bleeding and all that, I'm very happy that I don't have to do it. Okay? So the types of debridement are autolytic. So autolytic means that my own body is taking care of that. So once in a while you'll see these wounds and they might have a thin yellow covering over them, which you don't want to confuse with slough, because that thin yellow covering over the wound is autolytic debridement. That's your white blood cells and your leukocytes coming in that area trying to clean it up. Okay? So it looks different than the slough because it's just a very thin, kind of watery looking layer, versus the slough is going to be more thick. Okay? Enzymatic or chemical, so that's what I was talking about. There's enzymatic debriders. There's really only kind of one. Chemical would be with the silver nitrate. Okay? Mechanical, that is when we do a wet to dry dressing, technically you're doing mechanical debridement. Okay? Because when you put in something wet, you take it out, 24 hours later, it's not going to be as wet as when you put it in. And you're going to be removing good tissue and bad tissue at the same time. Okay? Sharp debridement, like I said, that's usually done by a surgeon or a trained wound ostomy continence nurse. Okay? So this is just a little chart. I know it's hard to read, I'm sorry, but this talks about the different type of enzymatic debriders. So the most common one is up here. It's the collagenase. So that has to be put on daily, and People try to use it sparingly. Please don't try to use it sparingly, because if you try to use it sparingly, you're not going to get the proper effects. It is very expensive because only one company markets it. So, but it does work well to clean up wounds, especially in your patients that are not a candidate to go back to surgery. Okay? So managing moisture. Okay? So this is going to tell us about how do we select our dressings. I'll tell you the one way I can cheat, and I tell the nurses all the time, if you're really not sure what to do, use a foam, right? A foam dressing will keep the area moist, but at the same time, if there's too much exudate or too much drainage, the foam dressings can typically handle up to 3 times their own weight in drainage. So if it's the weekend and you're not sure what kind of dressing to put on it, put a foam on it, because you're really probably not going to hurt the patient by doing that, but you're going to at least be starting some type of an intervention. Okay, so this is talking about what we've been saying. The ideal healing environment is it's moist. So if it's too moist, we have to put on something to absorb. If it's too dry, we've got to add moisture. So if you kind of always keep this in your mind, it will guide you on how to take care of some of these wounds. Okay, so wound packing. One of the most common things I see with wound packing is it's either too tight or it's too loose. So when you're packing a wound, I usually use a cotton tip applicator when I pack a wound. You want it to be packed firm. The reason is, if you pack it too tight, you're going to impair that tissue that's trying to heal from the wound base up, because you're putting too much pressure on it. If you pack it too loose, you're going to allow things to accumulate like pus and all kinds of crazy stuff that you don't want in your wounds. So there's a fine line, but you can kind of, when you've done it, you'll kind of get a feeling of how it feels when you get it in there firm. Okay? So you always want to use one piece of roll gauze. It makes me crazy when I go in and I see 24x4s. Okay, because how do I know that the nurse before me, because most of the time they don't document it, how do I know I've gotten all that foam out of the wound? And I'll tell you what's worse is sometimes these surgeons, they do these huge abdominal things, and you're going in, they want you to put a wound vac on it, right? So you're going in, I mean, you're just taking out roll after roll. So we're trying to get them to tie them together, but that hasn't really taken off yet, but I'm not giving up. So you really want to use one continuous piece of whatever you're packing a wound with, because then the next nurse may not be you coming along to take it out, and that way they can ensure they get it out, okay? Sure, some of these wounds aren't very deep, so this may seem pointless, but when you have a huge abdominal wound that the surgeon has packed with 6 rolls of Curlex gauze, it's critical that you know you've gotten everything out of there, okay? So that's my piece of advice about that. You also want to, I don't know how we got out of this practice, but we should be dating, timing, and initialing all dressings that we do. Why? Because we need to know. And if I go in and see the nurse just changed a dressing 2 hours before I get there and it's saturated with drainage, that's going to impact what treatment I'm going to use. But if I don't know how long that dressing's been on, it's going to be hard. And if the surgeon comes in or a doctor, it's also just helpful for them to have it right there. Okay. So this is a wound assessment tool. Similar to the Braden, there's a Bates-Jensen wound assessment tool. It's mostly used in, does anybody here work like in a SNF or LTAC? Okay, good. So you've seen the Bates-Jensen tool probably? No? No. Okay, so the Bates-Jensen's tool is a document that you document the wound, and it has all these different characteristics of the wound. And it helps the next provider know, is that wound staying the same or getting better or not? Okay, so it's just another tool we can use similar to like the Braden scale is used for risk, but the Bates-Jensen is a wound assessment tool. But it's a tool that we have as practitioners so we can tell, is that wound getting better, getting worse, what's going on? It, you know, it has measurements, it has descriptions. So it's just a good tool to know about. But we really don't use that in acute care, okay? So when we were trying to come up with our treatment plan, how do we cleanse a wound? There's a whole debate about what do you use to cleanse a wound. I don't think anyone's ever proven there's one thing that's better than the other. So at St. Joseph's, we just use normal saline. A lot of home healths use wound cleansers, which are a high percentage of just normal saline. So there's not any evidence that I've found yet that says one thing is better than the other. The main thing is that you're cleaning it, okay? And your dressing choice, of course, is going to be based on your treatment goal. Are you trying to heal that wound? Are you trying to just keep it at bay? What is your goal for that wound, okay? Remember your acute wounds versus your chronic wounds. Chronic wounds take a really long time to heal, and that's why they're chronic. So once they're 3 months or more, for chronic wounds, what you need to be thinking is there's an underlying issue that you need to address before you're probably going to get success of wound healing, okay? You want to know what your resources are. How much pain is that for the patient? If it's a painful wound dressing change, you want to make sure you're medicating your patient for pain before you're doing dressing changes. Okay. So this is talking about infections. If you know you have a wound infection, you may want to choose some type of an antimicrobial dressing. They're out there. If you do see maceration of the wound, it's normally because the person who packed it before you left gauze hanging out all over the outside of the wound, and maybe they didn't put skin protectant or something around it, like a skin barrier. So, those wound edges, if they get too macerated, that skin's now going to fall off, so then your wound's going to get bigger. So you want to make sure that if you're packing a wound, you're packing it just in the wound and not having stuff extend out, okay? You've got to protect those wound edges. If you have a wound that has any depth, you want to pack it. So even if you had a wound that has depth and you're going to use a foam, you probably need to pack it with some roll gauze, moisten with saline, and then put your foam on, because you don't want to leave a lot of dead space, okay? If you've got necrotic tissue, you've got to get that off of there, because again, as long as it's there, you're really not going to be making any progress, okay? Rolled wound edges, those, as I said, can be treated with like silver nitrate, or you can just kind of cut them to re-traumatize them, okay? So now we're going to talk about some other wound types, in case you guys have seen these. So these are the other most common: arterial, venous. We say neuropathic or diabetic. It's kind of one and the same. We've already kind of covered the skin tears. But this is a good example of someone with an arterial ulcer. Okay, so, and I have to tell you, a lot of these patients, if they have arterial or venous, a lot of times it's a combination. And the only way you really know is if they've had, vascular studies done, or ABIs, or for our diabetics, we do TBIs, which is a total brachial index. But in acute care hospitals, we don't do that. But you guys may see that on an outpatient setting. Okay, but it's going to drive your treatment. So if you're going to be considering compression, which again, if I have an arterial ulcer, I know my patient has impairment. So, I have to consider what things can I do to help that disease so that I can get healing, okay? So you're going to see the characteristics: absent or diminished pulses. A lot of times they have pain on elevation. The skin's going to be kind of shiny. A lot of times the toenails look thick, but I think as we get older, our toenails just get thicker anyway. Absence of hair. But the thing that's going to define your arterial is a lot of times they are located distally. So you're going to see them on toes, fingers, and they're going to have this like punched out look, just like someone took a cookie cutter, and punched it. Okay, so that's going to help you kind of to know that that is a wound that has an arterial component. Okay, and again, on this wound, it doesn't look super wet, so we're not, and it doesn't look super dry, so we're just going to try to protect it and allow it to heal. But again, until we get a vascular surgeon in there or something to take care of that, we're not really going to make much progress. So now compared to the venous, you'll notice the venous. Now this is a very good picture of maceration. So if you've never seen maceration, this is what it looks like. It's like white, and if you clean that off with just a 4x4 with gauze, you're going to see probably some of that tissue is going to come off because it's just so fragile, okay? But on your venous, a lot of times they're going to be on the leg. You're going to see hyperpigmentation, which I have on the next slide a very good picture of, hemosiderin staining. So the reason that it's called hemosiderin staining is that the blood gets trapped between the tissue, and so then the heme from the blood stays into the tissue, and that's what causes the darkening of the skin. It's usually in the gaiter. A lot of times they have edema, but now compared to the arterial, these have a lot of weeping. And you notice that the shape of this is a lot more irregular. It doesn't look as punched out. It's not as nice. And it's a lot of time, it's very shallow. But even though it's shallow, it has a lot of drainage. And a lot of times they're going to have palpable pulses. So this is a wound that you're going to have to probably treat, differently than your arterial one, because we've got to manage all that drainage. And on the venous patients, a lot of times once they've been checked with their ABIs and their vascular studies or whatever, then you may do compression therapy. But you don't want to do compression therapy on someone that hasn't been checked, because you don't want to impair their circulation further, because then that would put your license at risk. Okay, and ACE wraps and compression therapy are two different things. Some doctors will tell you they're not, but I'm sorry, I know they're different. So compression layer wraps is like a 3-series thing you do, 3 to 4 layers versus just putting an ACE wrap over somebody. Okay, can't be substituted. So this is that picture that shows the hemosiderin staining. So see this darkening here, the pigmentation, and see it here around this ankle. It's just, once you see it, you're going to know. And the other thing that you can't see super well in this picture, but the legs look like an inverted wine or champagne bottle. See how it's skinnier down at the bottom and kind of wider at the top? That's another characteristic that you're going to see in your patients that have venous. Okay? All right, neuropathic diabetic. Okay, so we know these happen because, these patients step on things and they have the neuropathy, so they don't even know they've stepped on it. Okay, so they're usually going to be on the bottom of the foot. So if it's on the bottom of the foot, it's usually not going to be pressure. But you see this little area around here, so that's different than the maceration, because when you look at it, it's hard. So that's actually a callus. So when you see a callus around the wound like that, that's a cardinal sign that it's a diabetic or neuropathic ulcer. Okay? And these really, you can do some local wound care, but you're going to need to send them out to podiatry, because podiatry has to debride this callus around it, and they probably need to get specially fitted shoes. There's a lot of things that need to happen. Okay? This wound here in the picture looks pretty wet, but a lot of these wounds look very dry. So you're going to see a variance. There's no cut or dry, okay? But, I could tell you stories about patients that have walked around with things in their foot for their whole day of work and don't notice till they get home and take off their shoe because of this neuropathy. So it's a big problem. Okay. So now I'm showing these two wounds. So what's common with these two wounds? What? Slough, yes. Right. They all have like some induration and redness going around. This one we can't really see, but it probably goes underneath because there's really nowhere for us to measure. This one we might be able to measure. So remember, when you're measuring around, that's called undermining. So undermining, again, is described for fellow practitioners the same manner as a clock. So once you do your measurement, you would say, undermining of 2 centimeters from 12 o'clock to 3 o'clock or whatever. That helps the next person coming in know, especially if someone's going to be packing that wound. You want to make sure they're not just packing right here. They need to know they need to go underneath, right? So you've got to guide them. But yes, both of these also probably would be considered unstageable, even though this one has a little bit of tissue you can see here, but this one's just got so much slough and stuff going on. Who knows what's going on under there? And this one, you can't see a darn thing. So definitely unstageable. Okay, now I'm going to tell you, so I'm saying how would this treatment differ? So this is a what? We saw a picture of it earlier. SDTI, right? So suspected deep tissue injury. This, in case it doesn't show well for you, is dry eschar on the heel of a diabetic patient. Okay? So, the reason I have this slide up here is as it's a reminder, okay? If I have dry intact eschar on a diabetic heel and I don't see any redness, I mean, this is betadine, but there's no redness or inflammation, it's not boggy, okay? I am not going to touch that. It's a diabetic. I don't want to make it worse, okay? I'm going to leave that and just kind of protect it, keep it clean and dry, because hopefully the body will just heal itself and we won't need to worry about it, okay? The suspected deep tissue injury, though, I like to keep my suspected deep tissue injuries open just so that the nurses remember to look at them. Because you put a foam over them, our protocol is you change a foam every 3 days. So in 3 days, when you take this foam off of here, who knows what that thing could look like. So as long as they're closed, you just keep them open, keep an eye on them. You're going to be offloading both of these heels, right? Because you don't want extra pressure. But on your diabetics, it's really important if it's a dry, intact eschar, you just keep it intact. Because you really don't want to try to debride that, remove it, do anything fancy like that, because you're probably going to have the wound that's going to get way bigger before it gets better. And remember, the diabetics are already impaired. Okay? So, here's a picture. So, if this patient came in, what would you guys say about this patient? So, everything's kind of closed, right? So, and this patient has a lot of hyperpigmentation. Well, that brings up another point. A lot of patients, when they have, darker pigmented skin, right around, if you open their crack, you'll notice they have darker tissue. That's just normal. That doesn't mean there's anything going on there. So you kind of just have to look at people and know, is that normal or not? But this person has hyperpigmentation, right, is what I would call that. But see right down here, this area is actually hypopigmented, right? Now, does anyone know why that might be like that? Scarring, exactly. So this patient has a scar, okay? So when I see that, that lights up in my head, oh, there's a scar there. So that means the patient had to have at least a full thickness wound that has healed in the past. Now, does that mean I know what stage it was? No, but I know it was full thickness, which means I need to be extra cautious with this patient because they are going to be at very high risk for breakdown, okay? Even sometimes this hyperpigmentation is caused from previously healed areas, okay? But most of the time, you're going to see this hypopigmentation, and that's going to clue you in. That's a scar. That means that tissue is more fragile. I've got to be cautious, okay? So now this picture, does anyone have any idea what this is? This is actually a patient's ischial tuberosity. And you can see kind of in here. So this was a patient who was a quadriplegic, and so he was in bed all the time. He actually had wounds like this bilaterally, okay? But the reason I have this picture here is this is a perfect example of granulation tissue, okay? You want that red, beefy, shiny looking tissue because that means it's healing. That means it's good tissue, okay? When you see it pale and pink and you don't see that, I mean, it doesn't mean your tissue's bad, but this is just a good example of what we would call granulation tissue. So this means that this wound, and this patient had a wound vac on both of the hips. So when we took it off and we found that, that was pretty amazing. So that's what you want to see in wound care. Do I see it very often? No. So, hopefully you guys will see it because that means what you're doing is working. But remember, since I'm in acute care, my patients come in and out. So I don't get a chance, unless they're coming in and out and in and out, I don't really get a chance to see them healing. So, yes. not typically, because we have such a trouble with getting a clean specimen, a clean, we could do it ourselves, but most of the physicians, even our infectious disease doctors, say that they really, if it looks infected, they're assuming it's infected, then they're treating it. So it's not something that typically in acute care, I think that in outpatient care it would be useful, but you also have to make sure you're collecting the specimen correctly. So, you want to clean the wound before you do your specimen. And that's a mistake a lot of people make, is they just take the dressing off and start swabbing. And you also have to make sure you don't touch anything on the exterior part, because then you can get some of that cross-contamination from something that just might be on the skin. Yes?
Is it for clean or unclean wound you only use normal saline?
Yes, we just use normal saline on everything. So to me, some people say, wound care is a clean procedure. It is not sterile. There's no way in the world you can make it sterile. I'm sorry. I learned sterile dressing technique in nursing school, and you can try to keep it sterile, but when you're talking about wounds, you're talking about something that's just going to be kept clean. So you try to use good technique and keep it clean so you're not cross-contaminating. Yes?
You showed pictures with small hole openings with significant amounts of undermining. What do you use to guide the decision to maybe open that and let it heal from the bottom up?
For those, well, it depends on if the patient's a good surgical candidate, but a lot of times we'll get the doctor involved and we'll have a surgeon come in and they will make that decision on whether did they want to surgically debride it more, or is that something we're going to just be packing like wet to dry every 24 hours and just, trying to optimize nutrition and stuff like that. So it all depends on what your ultimate goals are for your patient. And if a patient, most of the time if the patient can have surgery, they will go to surgery. And you're right, to make that wound get better, they have to make it bigger, and then you can see everything and you can do your treatment and go forward. So, yes.
What's the difference in the management between just moistening the slough and eschar? When you're not talking about a diabetic patient, when you see eschar formation, is it an indication that the eschar needs to be degraded, or should you be?
Well, eschar tends to be a lot thicker and harder if you've ever seen it compared to slough. So a lot of times, if you're treating that, you have to, so in the outpatient world, you have to probably cross-hatch it or injure it somehow so that whatever you're putting on the outside can kind of get in. Slough, you wouldn't have to do that with because it's already moist and kind of looser by its own nature. But it still needs to come off, yes. So a lot of times when you're talking about slough versus eschar, when you're talking more on the eschar end of it, you probably need to have more of like a sharp debridement done by a surgeon so that you can kind of jumpstart that wound. But again, it all is based on what are your ultimate goals for your patient. So, and I didn't tell you guys, but up here on this front row, there's a little sheet that I have. It's not on my PowerPoint, but if you'd like it, it's just a little chart I have that kind of tells you what to do for wounds. If it's too moist, use this. Too dry, do that. So, okay. Oh, yes.
Do you have any comment about burns?
About burns. I don't do a lot of burns, but when we do burns, we usually use the sulfasalazine as long as the patient's not allergic to it. Yeah, or you can also use Santel is good on wounds as well. So, yes.
Regarding skin tears, I see a lot of them, and I do try to reapproximate. Would you say the rate of infection is after those happening? Do they clear up pretty good? Because I never get to follow up.
Yes, if you reapproximate them. So if anybody didn't get a handout, come and see me. I'll take down your email, and I can email it to you. But they don't, you don't typically see them, but they do typically heal. If you reapproximate them and then you just trim the steri strips as they come loose, then you're usually in good shape, because that hood doesn't take that long, which is why it's critical to bring the hood over as soon after injury as possible, because I don't know if you've ever done it on someone maybe past 24 hours. You're going to see it's kind of already stuck and you can't move it. So the more you can approximate that, then you're going to get a better sealing, okay? And usually just by approximating that and covering it, you're going to prevent infection and you're going to promote better healing of that whole area. So good questions. All right, thank you all very much.